Thank you, everyone. The first of the eminent speaker on this panel is going to be Prof. Dame Praveen Kumar. We all know her very well, and we also know that she is mother or grandmother or great-grandmother of medicine, and it will be a great pleasure to invite her to the dais and give this speak. And before that, what all we have missed about her introduction, I'm just going to tell a little bit more about. And she's, we all know that she's been Professor of Medicine and Education, worked in Bath and London School of Medicine, and associated with Queen Mary University of London as well. And she's been President of Royal Medical Benevolent Fund, and also the Chairman Board of Science, BMA, and previous President of BMA, Vice President College of Physicians, and she also the Chairman Medicine Commission of UK and founder non-executive director of NICE. So I would like to invite Dame Professor Praveen Kumar to deliver the lecture, please.
Thank you very much, Mahesh and Anuma. I did have a talk, and I'm not going to change it totally, because we've had such a wonderful day with all sorts of excitement and things that we should and shouldn't do. So mine's going to be slightly philosophical. I hope you don't mind. Now, is the NHS fit for purpose? Well, clearly at this stage, the answer must be no. We cannot do what Bevan said. But yet I do feel that the basic principle of what Bevan said must carry on, and that is free at the point of entry and looking after the whole population. So I'm going to divide it up in my next 9 minutes, because I can see the count coming down, into medicine, into population health, and into society. So looking at medicine, as Uma's just said, it is changing. It has changed. It has changed beyond anything I could dream of. You know, I used to love coming in. I worked for the NHS for 43 years, loved every minute of it, came in. What have we done to our juniors that now they don't want to do it? Why is it that 65% of doctors do not want their children to do medicine? There's something gone wrong. And I think part of it is the huge intensity of medicine, but also the changes that Uma was telling us about. We've now got new genetic medicine. We've got, you know, really, really expensive but really effective treatments. We're going to be having personalized medicine. It's not going to be one medicine fits all. It's going to be each of us is going to have different things. So that's really changing enormously as we go. But along with that is the pressures on the staff. And I don't know what the new doctor in the future is going to do. I really don't know what the role will be. Because I think at the moment there's so many things, and thank goodness, you know, we are going across nurses doing doctors' work and pharmacists prescribing. So I think we need to know what our role is going to be in the future, because it's uncertain at the moment. The next thing, if you look at population health, we've already heard is getting older. We're going to double our years. A 65-year-old now is like a 85-year-old in the olden days. Oh, sorry, 85-year-old like a 65-year-old. So we're all going to be living longer. And along with that comes comorbidities. A person over 65 spends 14 times that of a person who's a working population in terms of healthcare costs. So not only are we going to get older, there's going to be comorbidities, and that's difficult to sort out, and that's going to be more expensive. So the whole situation is going to be expensive. Now, if you look at the patient side, and let's look at the population health, we've got getting older, we've got obesity. Diabetes per se is going to wipe out all the NHS funds if you're not careful, more careful about it. We've got alcohol problems, we've got a lot of health problems in terms of self-inflicted health, and we've got to really educate the population, because otherwise we can't afford it. And then if you look at society, society is very demanding. We already had a little bit about what society does and can't do. But society is dictated by, I don't know where our press person's gone, but it's dictated by what the press says. And now everybody expects everything. You know, you can't sort of choose what you want because the expectation has gone up. Every time you turn the television on, there's a new soap where everybody's, you know, well at the end of it. No, they're not dying, you know. And I think the patient expectations is gone so high that we cannot deliver that. We need to have some sort of way that we can re-educate the patient's expectations and be able to deliver them. So what are the solutions? I mean, we're really in a mire of 3 different things coming down at us. Well, one of them, I think, if you don't have a good, happy staff, you're not going to deliver anything. We've got to do something about our juniors, indeed also about the nurses. We've got to look after them. Simple things like saying thank you to them, valuing them, giving them somewhere to lie down and sleep. I mean, this doesn't cost very much. Giving them hot food at times that they can't get it. This for a trust doesn't cost very much. And they've got to be really cared for and looked after and make sure that they have good mentorship. That whole business about the firm system had to go because of the shift work. Now, various other countries have managed that. I don't know how they've done it, but we can do it. We can somehow rechange it, that you have your consultant who looks after you and mentors you and takes you through. We don't have that. Secondly, what can we, the patients demand a lot of things, but we need to get some sort of idea that the patients must realize that, we can't deliver everything. And one of the worst things possible is we've lost the trust. We've lost the trust of the patients. We need to have an honest discussion with the patients and the population of what is logical, what is possible, what is evidence-based, and what is affordable. And I think if we can't do that, we are totally lost. So that is my 9.5 minutes. Is that all right? Not yet. Well, what else do you want me to talk about? So, all right, so let's just look at morale. I think somehow we've got to bring that morale up. Now, how many of you, sorry, just out of interest, how many of you have children who are going to do medicine? Oh, sorry, children who might do medicine. All right, and will you let them go and do medicine? You will? Well, the RMBF came out with a thing that 65% won't allow their children to do medicine. The other thing, now that I've got half a minute now, the Royal Medical Society have done lots of very good work. The anxiety levels and the depression levels and the mental health levels are so high. I mean, what are we doing to our youngsters that we're making them feel that they can't practice? And if you're depressed and you're lonely, we talked about that earlier, you cannot practice well. So somehow we need to support them to be able to do that. So if anybody knows anybody who's got no money and is really unhappy and so on, please let us know about that. Equally, with the RMBF and the BMA, we've also got the Doctors' Health going. And the 380 or something have actually phoned up in the last 18 months. And this is the tip of the iceberg, so I think we really need to look after them. So going back to the question, which was, is the NHS fit for purpose? The answer is no, but we cannot let it die. It's the best system in the world, and somehow all of us have got to work out. We can't get more money. I mean, we, of course, love more money, but I think that little thing we talked about, Ramesh, we talked about just now, about trust getting together and not over-investigating. And one of the things, I write this bloody textbook, but one of the things that I find quite difficult is taking away things. People will go on doing Bayesian follow-throughs, but you don't need them now. You don't need to fry people with CT scans. And I was doing a ward round in the Mayo Clinic early one morning, and a girl with typical IBS symptoms came in, and what did? They fried her with a CT scan. Why did you do that? Because of legal medicine. Suing culture is coming over, the blame culture is there, but I think what we do need is an honest discussion with the population of what we can afford. Thank you.
Our next speaker on this particular topic is going to be Professor Andrew Goddard. We all know him as Bod. Professor Goddard qualified in 1990 from Cambridge and then went on to the postgraduate education in Nottingham. And then he was appointed as consultant physician and a gastroenterologist in 2001. And then he was appointed as a chair of British Society of Gastroenterology and Gastroduodenal Section. And he was a director of the Royal College Physicians Medical Workforce Unit for 5 years until being appointed as a RCP registrar in 2014. Now, in 2018, he was elected as the 121st RCP president, the youngest for the 400 years. It's an immense pleasure to invite Bod onto the stage to give us on the.
Thanks, Mahesh. Afternoon, everybody. I've got man flu, so I don't normally sound this husky. Everybody thinks Nye Bevan was the originator of the NHS, but actually it was Winston Churchill who first responded to Beveridge's report and said we need a national health service. Ironically, though, his party, the Conservatives, fought against the formation of the NHS because Labour took power, and it just goes to show that actually politicians will put political needs over perhaps the country's needs sometimes, particularly when it comes to health services. But that's enough politics. So I think it's very clear, we know what the NHS is there for. We have written it down in our NHS constitution. So if we're going to judge, is it fit for purpose, how do we currently match up to the NHS constitution? And there's the phrase, it's there to improve our health and well-being, supporting us to keep mentally well and physically well, and then to get better when we are ill. I think most of us in this room spend most of our time doing that bit, getting people better. But the NHS should be there to keep people well, bringing the highest levels of human knowledge and skill to save lives and improve health. And there are 7 principles. Comprehensive service available to all. Does it do that? Yes. I was in Walsall earlier this week, and I was, just as I rounded the corner from the station to get to Walsall Hospital, it just suddenly struck me, there was a hospital. If I was knocked down by a car there and then crossing that road, I would be admitted to that hospital, I would be treated, and I would be made better, irrespective of my pay packet. Access based on clinical need, I'll come on to the data about that. I think we're doing less well at that. Aspires to the highest standards of excellence and professionalism. I think we aspire to that, but money is now stopping us achieving that. The patient is at the heart of everything it does. I hope so. I hope all of us in this room put patients first, and the reasons that we do things we do for the patients, not for our own or professional needs. And I think that's one of the concerns about private healthcare, is that money then becomes more of an aim rather than patient care. Working across boundaries. For all the problems with it, the sustainability and transformation plans are trying to do that. Integrated care systems are the vision to get things working across boundaries, and we need to do that. Best value for taxpayers' money, I'll come on to that. Accountable to the public, communities and patients, sort of. Okay. Are the public happy with the NHS as it stands? So this is basically the question in the National Attitude Survey about people, how they feel about the NHS. Since the early 1980s, there are some missing data points because people were not asked that question that year. But basically, this is the group, are they happy or are they unhappy? So what you can see is in the past few years, people have generally become less happy. If you look down here, they were unhappy, lots of money pumped in during the Blair years, people got much happier, but now, and particularly the impression is this year, this is going right down. And that may well be a stimulus politically to more money going in. Are we any good? So life expectancy over the past 15 years has gone up. Year and a half, I've done this for women, year and a half, but here's an interesting thing, that the life expectancy in years of poor health has also gone up. And that's a challenge for us. It means the people that are coming into hospital are in poorer health than previously. So you have to work harder on those people. They've got more multimorbidity. And one of the reasons that that the system is struggling is because of multimorbidity. Yes, it's aging, but those older people have more multimorbidity. 20 years ago, if you made it to 80, you were 80 and fit. These days, you make it to 80 and you can be 80 and unfit. CQC ratings are a good way to assess how good we're doing. GP care at the top, so lots of green. Adult social care services, a fair bit. Mental health services not doing quite as well, and acute care services not doing. So I say all of these things to say that the health system, the NHS as a whole, is doing okay, but clearly there are some amber warning lights coming up on things. This is the 2 years between 2018 and 2017, and that would suggest that actually things are a bit better this year based on CQC inspections than they were last year. This is my graph of doom, and anybody who has seen this before, I apologise, but to me it sums up the NHS in one slide. I became a consultant in beginning of 2002. This is the number of emergency admissions to NHS hospitals since then, rebased to 100%. And up to last year, it had gone up by 51%. In the same period of time, the number of beds had gone down by 26%, and the only reason the House of Cards has not collapsed since then is because of the bottom line, the red one, which is length of stay. We've got more and more efficient. This is emergency admissions, this is not elective admissions, we're not talking about day case surgery, we're talking about how quickly we get people through the system. But this level is now levelling off, and certainly in Derby, where I work, we are now in the process of building more beds. We're trying to build onto the side of the hospital more beds because we've run out of capacity. If you want to have a really good idea where we're at, I would recommend the CQC's document, The State of Healthcare. And there are lots of graphs in there that paint a worrying picture. Number of patients waiting to start on the 18-week, going up and up and up. There's 2011, 2018. Monthly performance against the 4-hour target in A&E. It's an emergency care standard target. It's not just A&E, but A&E is where you see it. You see the ambulances queuing up outside A&E. You don't see them queuing up on the wards, and you don't see them in medical wards where we do 74% of all emergency bed days, just as a plug for medicine. But this is getting worse and worse. Rates of avoidable admission in older people up by 24% over the past 7 years. That's 90-year-olds, and then you go down to 65-year-olds. This is the problem. Lots of people in care homes, lots of people in residential homes coming into hospital in avoidable ways. The NHS is having to support the social care system. And if we don't invest equally in the social care system as well as the NHS, our problems will only get worse. Earlier talked about variation. I'll just pick this from random, from the surgical GIRFT report, just to show this. This is the proportion of patients having major colorectal surgery where it's attempted laparoscopically. Just to show, there are dots all over the shop here. There's no consistency there whatsoever. To say that we have a problem with variability of care in the NHS is an understatement. And I think until we can prove that we have reduced variability, and that's why I'm fully supportive of the Getting It Right First Time programme, it's very hard for us to go to the public and ask for more money. Simon Stevens uses a wonderful phrase. He says we have to make the NHS an investable proposition. And until we get rid of variation like this, I don't think we have. So we've got to get our house in order. But we have problems, and my big thing, as you've heard, is workforce. So in medicine, so the medical specialties, that's about a third of all consultant posts. This is the number of successful appointments to consultant posts over the past 10 years. 20% were unsuccessful back in 2007, 45% unsuccessful in 2017. There's a gap. We are not training enough people. The NHS is poor, it has no money, but still it will employ expensive doctors, and it asks and asks for them, but there are not enough. The number of gaps on trainee rotas is inexorably rising. The number of consultant physicians per head of the population is very variable. I work in the East Midlands. We have the lowest number of consultants per 100,000 in the country. It's not surprising, therefore, if you work in Derby or Nottingham or Boston, that you feel that you're working very hard and under pressure. But there's a bit of a crisis looming. Now earlier, our politician guest asked us to be consistent about what we asked for, so I'm very consistent about what I asked for. We need to double the number of medical students. If we don't double the number of medical students now, in 10 years' time, we are screwed. And you can quote me on that. This is the population of doctors by age and gender. So the current group that are retiring at the moment are predominantly male. There, okay? The group that will retire in 10 years' time, there is a shift of demographic, but there are double the number. I've just shown you we can't train enough to recruit what we currently need, and we need to do at least double just from retirements. We have historically relied on overseas doctors. This is the number of people, proportion, coming from overseas, and there was a big drop-off in 2007. So when those people retire, we are in big trouble. The way people work is changing. The proportion working less than full-time is inexorably rising. So that demographic, not only are double the number retiring, the people that are going to replace them are far more likely to work less than full-time. So you can't just do it on head count. You've got to think in full-time equivalents. So if you do the maths, and you can do it, I can give you the hard maths for medicine, and you roll it out to all the other specialties and general practice, you have to double the number of medical students now in order for us to not be in crisis in 10 years' time. What are we going to do in the intervening 10 years? That's where immigration has got to change. We've got to be much more reliant on the overseas profession, as we have done previously, because if we don't do that, we will get in trouble before then. So, in summary, is the NHS fit for purpose? So, yes, I think it is. I think we're okay at the moment, but in sporting terms, we're a bit overweight in some places, and we certainly haven't done enough training, and other members of the team, social care, are really struggling. So I think it's very unlikely that we're going to win many matches in the next couple of seasons. I'm happy to talk about that further. Thank you.
Praveen Kumar, and also I would like to invite at the same time two other panelists. One is Stephen Parsons, who's representing on the patient's behalf. He's a patient's representative. To give a brief introduction of Mr. Stephen Parsons. He's chair of a Bristol Cathedral School, Deputy Lord Lieutenant, and here is representing the patient perspective, and thank you very much for being here with us. And other panel member would like to invite is Dr. Kailash Chand. He's from Greater Manchester. He is co-chair of diversity, and also he's quite a prominent writer in Guardian and Pulse, and also he quite passionate about the NHS funded and accountant sections. We'd like to invite Dr. Chand as well. So I'll hand over to our chair, Uma, to take the floor questions, please.
Thank you, Mahesh. So that was an excellent overview. I'm sure we would all agree. Now it's time for questions, and we'll open it up. Can I just, before I start, can I just say that Parveen is not a mother or a grandmother, but a daughter of medicine. Thank you. So the questions now from the floor.
Arvind Shah, pediatrician, North Middlesex. One, I think, question to the panel, and which is puzzling me quite a lot, is over the year, I've been in this unit for like 20 years as a consultant, and our number of staff supporting that unit has gone up by at least 300%. But when I see the junior doctors and registrars, I've never seen low morale like this. We do lots of intensive, including giving coffees and muffin and doing mindful stuff and catering for their needs. But they come and they go off sick like nobody's business, and the numbers are huge. my feeling is our government has not got it right. They've been devalued with all the strikes and things we had last year. And lots of people have left NHS, juniors who have been fed up with all the stretching about the working hours are gone. But I find it very disheartening, and they're more prone for mistakes, they're more prone for having sickness and all that, and sickness is so heavy. So I need some sort of guidance or solution to see how we can support them. Unless we support them, we are not going to move forward with. And I work in pediatrics. It is an intensive branch. And it's mainly run by flexi trainees, more females than male and things. So I think, so I need some advice and solution for this.
Thank you. I think, Parveen, you raised the point of depression and low morale with junior doctors, and it appears as if you are recognizing them and somewhere rewarding them, but still asking for help because it's not correcting the situation. So maybe, Parveen, you could answer that.
No, I think really just to sort of enlarge on what I was saying, you're absolutely right. I mean, what have we done to our, they're bright, they're the best of the world, best of the country, top 10%, top 3% probably, coming into medicine, we're destroying them within seconds. And, to have an increase in depression, anxiety, leaving, time off, it never used to happen before, and it's happening now. And, I don't know, I'm sure we can do simple things, but somehow we need to change the structure. And I think there are two things that really went wrong. One was, I think, the demise of the mess. At least if I got up at night, I would meet 5 or 6 other people doing the same thing. So we'd have a cup of coffee. My anxiety would be diffused by saying, well, I didn't know what was wrong with the patient, and they said, fine, this little carrot, he'll be fine till the morning when the boss says turn up. We don't have that. And the other thing really is the lack of the firm system, because I knew however hard I worked, there was always my boss who would support me, or the registrar. But now you're on duty with a registrar you don't know, or you might be the registrar on duty with a team you don't know. So it's very, very, it's anxiety prone. Yeah. And we just got to do something about that. And it could be just simple.
Yeah, very valid points there actually. And also maybe mentorship, somebody they could talk to, even if the mess cannot be brought back, because my own daughter, who is an F1, calls me every 48 hours with some issue that she can't deal with or she's afraid to deal with, and that brought home to me, what about the other doctors, junior doctors, who don't have a mother to pick up the phone and ask questions about? So it's a real issue. Andrew.
So I won't bore you with, I give a talk called Medicine is Brilliant, and so I'll happily come and give a talk to your hospital about that. I spend an hour talking through the psychological literature about what makes doctors happy and what makes them unhappy. When it comes to trainees, they're very clear. I spent several years going around the country figuring out and talking to medical registrars, and there are 4 things which basically define a medical registrar's happiness. Number 1 is workload, number 2 is the quality of education, number 3 is the team, and number 4 is flexibility. Okay, so when workload is as tough as it is, all of them go out the window, and unless we get the workforce bit right, workforce is the common denominator, so we need to do that one. There are lots of things that we individually can do in this room. So one of the things I say to guys when they pass the MRCP, and we have a lovely ceremony, and people are really positive, I say there's only 2 things you need to remember. Number 1, work hard. Number 2, be kind to people, okay? We must all beware the shadow that we cast, because if we turn up to work miserable, critical, our trainees will pick that up. We need to understand our trainees, and that means spending time with them. It means taking them for coffee or beer or whatever, and getting to know what their problems are, both at work, with their career, and at home. And we don't spend enough time with our trainees. We're all busy, but actually as GPs, consultants, SAS doctors, we have leadership roles in the team, and we've got to spend time and get to know our team better. I think if you do those simple things, actually it then becomes much easier. And then you start to work more as a team. We're never going to get the firm back because the trainees are very clear they don't want to work more hours. And I ask that at every meeting I do, and the trainees say they do not want to work more hours. So we have to work with what we've got, And that means that we, again, have to, as leaders, work a bit harder getting to know our trainees.
So simple things, saying thank you and acknowledging what they're doing, extra work that they do. It will make a big difference. It does make a big difference because a junior doctor is not confident, but a consultant saying you did a great job goes a long way for improving their morale and making them feel, oh yes, I'm doing a good job.
My name is Sethu Arya. I'm a pediatric consultant. I'm also training program director in the KSS Deanery. We have had 2 suicides in the last 1 year in our deanery, in the pediatric department. We have the lowest applicant rate, and we have the highest attrition rate right now, 30% attrition. Either they are dropping out of pediatric training or moving into other disciplines. So we had to finally come to grips with it. We had a meeting, and I've been appointed as one of the well-being TPDs. So we have had quite a few pieces of work around that. There are 4 things that you mentioned is really difficult. Number 1, they do not get anyone to listen to. They're very isolated. Pediatrics is very isolated compared to the other disciplines because medical trainees in the medical discipline and the surgical discipline do get to see each other either in the A&E or somewhere else. Pediatrics do not do that. They are very much relegated to their own wards or they're working in the pediatric A&E. So they do not have a meeting place, and mess is now gone. And the second thing is the workload and the higher increasing expectations. They're not just dealing with the patient, they're dealing with very anxious, very angry parents as well. So there are 2 people that we could deal with. A second thing. Third thing, what they experienced was when they go, we spoke about mentorship earlier, when they go approaching someone with a problem, what they get is solutions. They do not get listened to. That's the third thing they said. And fourth thing is with the increasing number of workplace-based assessments. It's gone down, which is a huge relief. These are the 4 things that came out repeatedly. But that could not have been the reason for suicide. That might have been, there have been other issues as well, which have been smoldering and carrying for a long time.
Valid points. Thank you very much indeed. Can we change the stream then from training and the issues relating to the morale to a different topic, one of the other challenges that the NHS is facing? If anybody is able to address a different question, can the mic go there?
Thank you. Yes, I just wanted to bring up about patient participation groups which belong to GP surgeries. Just out of interest, there's a self-care week coming up in November, and the whole idea is that it's encouraging patients to take more of a role in their own improvement in health and well-being. And I just felt that's quite valuable in terms of helping patients to see that the pink pill they've had for the past 3 years may not be the answer when they go back to see their GP again. You know, they need to be helped to look much broader than that. So I just felt that was it.
No, thank you. Thank you. So patient participation, awareness, regular review, those are quite key points. Jace, can we? Okay, is there anybody else that, I think there were a few from the back. More difficult questions as well to the panel.
It was a question for Bod and I guess the rest of the floor really, which is you mentioned the workforce challenges and your projection that we might have to rely again on being a net importer of healthcare professionals in the future. Do you think the UK is still a draw for those professionals? And do you think, 20 years ago we saw a big net influx of overseas doctors because the UK was respected as an area for good training? Their own healthcare environment and economy was not so well developed. Do you think that's still the case for the next 20 years, or do you think that that's something we need to think about and work on?
Yes.
Let me answer the first question. I've been GP for over 35 years, and all of you are from medical fraternity. Just think of it. Most of the patients, when they walk to your door, what are their problems? My guess is that 70 to 80% of the health problems are diet or lifestyle related. And until unless that responsibility is conveyed to them or understood by them, we are not going to do anything as far as the healthcare is concerned. I'm a great passionate supporter of NHS, but in my view, one thing which was fundamentally wrong right from the word the NHS was a part of our more or less day-to-day life, is that we have always worked on a disease model. What we talked about is diagnose and treat. You have all investigation, you have all the pill as you're talking about. I think we've got to move from that disease and treat model to a preventive model. And preventive model, again, can't work until unless there's a great participation of the patient groups into it. So I think you've got a very valid question, and particularly the whole theme of today's discussion is affordability. And I always say NHS is a great institution, it's affordable. Thing is that we have done it wrongly, and we got to mend that bit. If we do that, I'm sure we can sustain our NHS for another 70 years. Thank you.
Thank you, Kailash. Can I bring in the Mr. Stephen Parsons here as the patient representative to hear what he has to say about the whole issue and the NHS and how the patient's perspective comes into this?
So firstly, let me say, great conference, great energy in the room, many good ideas on the floor, they're not on the panel. And that needs to be got hold of. So wherever we end up today, I hope we're going to have an action plan, because there are incredible things which are being talked about, and we need to get hold of them and we need to make them happen. That means an action plan, and it needs management going forward. So that's the first thing I'd say. The patient point, yes, of course, we need a partnership between patients and the NHS and the doctors, and that means we have to work differently. And so I think I take the point that there is a responsibility on patients, but then there's different ways of working to encourage that and to inspire patients. Patients need to be inspired. You have all got the ability to inspire, and that's what you've got to do. So from a patient perspective, an inspirational doctor who comes to me and talks to me and sets me some goals, those are the sort of things I will want to pursue and follow. And I think many, many other individuals will as well. So be inspiring, be accessible, be kind, that was been said, and I think that's essential. But find ways that we can engage with larger groups. So maybe not just individual consultations, maybe there are group discussions with patients. So you're going to force multiply those you influence. You really need to do that, and it is a great partnership, and we love this NHS, and we've got to look after it. The NHS has been around almost as long as I have. And I will be desperately disappointed if we break the NHS, and we can't allow it to break. We've got to preserve it, but we've actually got to find different ways of making it work. We've got to be more efficient, and we've got to take this NHS forward into the 21st century, so my children and my grandchildren and their children will all be able to enjoy it and continue to have it to support them.
Thank you. I think the passion, the desire to keep the NHS viable is coming across quite clearly from everybody.
So a couple of things there. Group consultations was a bit of a news thing last weekend, and the RCP's been a bit involved with that. Just to say that whilst one of the patient representative groups, Patient Concern, said it was a ghastly idea, the 2,000 or so patients that are involved with it, 100% of them said it was fantastic. So I think there are new models and ways we can do things to make better use of our finances. So I was doing an endoscopy list yesterday, and I asked all my patients, did they think the NHS was fit for purpose? They all did, and one of them's comment, which I will say verbatim, was he thought, the NHS is bloody marvellous, doctor. Now, I did have an endoscope up his bottom at the time, and that might have influenced his view. But most patients, when they are in the NHS from a user perspective, think it is good. And I think that, to answer Peter's question, you know, we get calls from all over the world, can we send people across to train? You know, the NHS is still viewed by both patients and by people outside of the UK as a fantastic service. That's why I think it is currently fit for purpose. But we have to be really wary of what the future holds.
Thank you. Thank you.
Hello, I'm Deepak Migeri, the psychiatrist. I'm asking from doctors coming from India perspective. I think it's going to be incredibly difficult to get the foreign doctors as we, from our time we came. The challenges are different, but I have never seen anywhere any discussion about how you actually fit the retired doctors back into NHS. Though they are not for a full-time employment, but there are a lot of doctors who desires to work just 2 sessions a week or 4 sessions a week, And obviously the hurdles are like appraisals, GMC fees, and medical legal like MDS fees or MDU fees, and whether that can be accommodated by the government, the politicians, so, and supported by organizations like BAPIO and BMA, and they can come into kind of a different role, like they may not be in a responsible clinician, secretary, or a consultant. They may not like to, but they can still want to be wanting to provide that clinical care. And
Yes,
at the
thank
same
you.
time, there has to be incentives of privileges, whether they can have some NHS privileges, like
Yes.
pension, like every doctors have, and it's very popular.
Thank you. Can I please ask that the questions be kept to a very couple of points, please? But that's very valid points.
So easy answer to that. We wrote a report last year called Later Careers, which covers all of those things. The barriers that there are to doctors around the time of retirement within hospital medicine are exactly as you've laid them out, and there are ways that we can tackle each of those. The current burning worry is pensions. General practice has seen loads of people leaving because of pensions, and if we don't get that sorted out in the near future, I think hospital medicine and surgery is going to see the same.
I mean, so many points, models, and suggestions and solutions are coming across Parag. We need to make a note of it and make sure they're all actioned. Did you have a question on the BME aspect? Can the mic be passed on to you?
No, I just wanted to comment. In the morning, Setu presented 15% of UK population is BME, yet the representation on the boards at higher level is only 2%. And how and when are we going to address that?
I think that's a very, very valid question.
Can I respond to that?
Yeah.
I think it is a travesty that the BME population is not better represented in leadership in the NHS and in trusts, and it needs to be dealt with. And I think we all have to shout about that. I think the 21st century absolutely understands it. It's not acceptable. It's not acceptable from a leadership or a governance point of view. But we have to make the point. Our NHS are concerned. Parag is a leading light in that. It is a pressure group, and we hope it will be an influencer for the NHS. Let's start to try and influence.
Yes.
I think influence is good enough. I think most of us been talking and listening about this for God knows decades. And when you talk about to the people who have power, they also will always say, yes, there is discrimination, things needs changing, we will appoint a committee, have a board. I think Yvonne is sitting somewhere here,
Yeah,
and
Yvonne
Yvonne will perhaps be able to tell something that what exactly NHS England is doing. Now there is a board actually looking into the discrimination about it, but truth is just lip service is not good enough. We need action now. And unless action happens, nothing is going to change. I'm myself actually a co-chair of Equality and Diversity in Greater Manchester, and I find the discrimination bit is huge. And when you talk to anybody, they will all say, yes, it is. But what are we doing about it? Nothing is happening. I think Ramesh Mehta has done a hell of a lot to point that out, and he's even taken them to the court when MRCGP things were concerned. But have things changed? I'm saying Ramesh will also agree. Yes, we have made them aware, but that awareness now got to be translated into some solid actions. We've got to stand up and be counted. It's high time. Thank you.
No, thank you very much. I think, Professor Sandhu, the last comment or question, and I think unfortunately time is up.
Sorry, I missed a bit of your earlier talk because I've been chairing the research presentations, which were brilliant, and one can't be in two places. I think that out of the things that are really backwards, like in academic medicine, is the women who don't do that well in academic medicine. I think this business on the boards is probably where we've got the least representation. Now, that easy solutions, because what I found when I was used to chair the BMA Equality and Diversity Committee, there were lots of issues, but if you gradually work at it, they will improve. You might not get rid of them. So I suggest people like Kailesh and others use the data and write about it, because we're already getting, I think it was yesterday when it was announced that the Prime Minister wants pay for BME employees to be made open, just like it did for women. And it's brought about change for women, particularly in the BBC and lots of organisations. There were some people sort of complaining about the BME, but I think that's what we should do. If you actually sit down, that's the problem, it's a single problem, and there's a strategy, advertise it, influence makers, and then we have a team of people that we nominate. Because actually I've found people don't want to do it, they don't know how to be put up for boards, and if BAPIO was to set this as a strategy, it would work, but you supply, you know, a list of 50 from who they can choose, who are good quality, probably better quality than some of the people they have. But because most of the people here wouldn't put themselves up, it doesn't happen. So to sum it up, we advertise so people know there's a problem, and I think everybody sympathizes. We prepare, have a big list, and send it to when they're appointing board, and it'll change.
No, thank you. Thank you very much. Can I just thank the speakers, the panelists for an excellent session, and the audience too for such an active participation. Thank you.